All right, everyone's here for Epi Biostats, correct? Sure hope so. Otherwise, you're gonna be in for a rude awakening. No. Okay, so I don't have a microphone, so I'm just gonna have to speak up if I'm not loud enough. Just let me know. But you guys are a little bit closer, so it should be okay. Right. So this class is going to be probably one of the most exciting you're gonna do at any point in your educational career, if I had to guess. Really, just thrills, chills. I mean, this is it right here. Okay. Obviously, I'm being a little sarcastic. This is kind of like, you think about like breakfast foods, you think about like, nice scrambled eggs, it's like your CMS course. You think about, farm, maybe like some bacon or something. But like this class is kind of like cold, unsalted oatmeal. Like, I hate to tell you that, right? So my goal is to try to like spruce it up a little bit, like maybe add a little Cool Whip or a little butter or something like that. Try to make it a little bit more digestible, right? I love me some cold oatmeal, but not everyone else likes it as much as I do. Okay, so that's kind of the thing. This class is going to be made up and basically broken into two sections. There's going to be the biostat section, which will be first, which are basically going to be covering basically kind of the nomenclature we're going to be using, talking about study design. We're going to be talking about some of the statistics. I still have a hard time saying. We're going to be talking about kind of the basics of things. Right now, are there going to be a lot of calculations on these tests? Absolutely not, right? So if you wanted me to calculate a p-value, I would say I had no idea how to do that. I'm just going to Google a p-value calculator and put it in, right? Or I'm going to get some software or something. So don't be scared by the math. There's not going to be a ton of it, right? I can guarantee you that. However, the concepts are what we want to know, right? We want to learn how to apply these concepts, so that way when you're actually looking at an article from a journal, you can just read it and make some really good make some good conclusions from that, right? So deciding whether this is a good article, a bad article, is this actually applicable to my patients, et cetera. That's what the first section is. The next section is then going to be about epidemiology, so kind of getting into different types of studies where we're basically looking at kind of populations as a whole, right? So whether it be people who live in Florida or people who live in all of Africa or wherever it happens to be, we'll talk about the epidemiology aspects of things. So it's two tests. There's going to be also some journal clubs. This is where your class participation is going to come into play here. And in fact, let me pull that up real quick. Let's move on. So this is our introduction. This is where I'm going to try to get some buy-in from you guys and try to show you how interesting this class can be. Should you try to go in with an open mind, right? Is anyone a stats expert? Fantastic. So at least I know more than you guys at this point, so you can't prove me wrong. Because I'm sure if you were a stats expert, you could probably say, actually, that's not quite right. You may want to do this. Anyway. So some of the objectives we're going to be looking at, we're trying to delineate, for you guys, at least like the difference between like statistics and probabilities and why these things are sort of not intuitive. You'll notice whenever you ask me a question, like whether it be in physio, whether it be in farm, you ask me questions like, hey, what about X, Y, and Z? Do I ever say yes or no? Typically no. I'm like, well, it depends. Probably. Maybe, right? So I say words like that, not because I like to be ambiguous, but mainly because of the fact this is what statistics has kind of taught me, right? In all things in medicine, is there ever any certainties? Like even in life, there's death and taxes. That's about it, right? So again, that's all the certainties that we have. But I want to try to help you overcome those obstacles that are going to make statistics so hard. It's a very daunting sort of subject. And if you go and look at any random journal article, it can be pretty daunting to try to figure out like, well, is this a good article or not? And what a lot of people end up doing is just reading the abstract and saying, well, this says that this is a really great drug, or this is a really great procedure. And I'm like, you only looked at 10 patients. I didn't know it's actually good or not, right? We're going to be able to make those kind of steps to try to determine is the article's any good or not, right? Because this is important for our research. So specifically, because you guys are getting a master's, right? I think everyone will be a master PA by the end of this, right? At least a degree you'll have. You have to be able to do some research, right? So we're talking about graduate projects. Graduate project 1 is all just a research paper. You go and do your own research and then report back and say, what do you think about it? What does the level of evidence out there say about whatever topic you choose, right? And so this class is going to be the foundations for how you make those interpretations, okay? Anyway, then we're going to be looking at all the jargon, all the lingo. And again, statistics, 60% of the time it works every time, right? There's a lot of bad statistics out there, right? If you give me any bit of data, I can make it say whatever I want, right? So again, there's lots of fudging of numbers. There's lots of different ways to view data, things like that. I want you to be able to learn how to kind of cut through that and get down to the bare facts and decide, what do you think about this, right? So instead of someone just telling you, hey, this like a drug rep comes up and says, this is the best drug ever, look at these study results, you can actually go back to the primary literature and say, like, actually, that's kind of crap. That's not a very good study. I think this instead, right? Because I want you to be independent thinkers, right? So anyway, let's look at a very tangible, real-life example. Today is my wedding anniversary. I've been married 5 years today. Thank you. It's nothing to do with me. It's all her infinite patience. My wife, Jeannie, she's wonderful. She's at home with the children right now, making sure they don't kill themselves. 2-year-olds are very suicidal. I don't know if anyone's told you that. But it's one of these things where, I was able to use a little bit of statistics to kind of help out my living situation. So I'll talk about that. So again, as people, as human beings, we tend to jump to conclusions pretty readily, right? When we have new data that contradicts a conclusion that we've already made, we tend to question the accuracy, right? We try to figure out, okay, well, is that actually true or not? Oftentimes we get in these echo chambers where we have a lot of positive validation for things that we hold true, and oftentimes it can be very hard to break us of those opinions or of those beliefs, right? So I remember when I was coming out of fellowship, my wife was finishing up her 2nd-year residency. She was in Gainesville, I was in Jacksonville. We needed someplace to move to, right? We needed someplace to find some jobs, and so I found a job in Orlando at Nemours. And so I said, well, if we're both moving down to Orlando together, somehow I convinced her of that. Probably that diamond ring I got her probably helped with convincing. But I said, hey, let's move in together. And she said, no, we can't do that. She said, if we move in together, we're going to increase our chances of divorce. And I said, well, what's your source? How can you say that? What data do you have to prove that? She said, Cosmo. To which I said, I don't know about their scientific rigor of the Cosmo. So I did some digging. I said, well, let's find out. Is that actually true that you're more likely to get divorced if you move in together before you're married? Luckily, I found a CDC article. You can't get better than that. You can't get better than the government saying, hey, this is what we found. This is what we think, right? So I actually found marriage and cohabitation in the United States. This was done a few years ago, as you can tell. But interesting results. So I went through. And they were looking at these couples basically, and they were looking at how long their marriages were lasting. Looked basically, number of marriages up to the 10th anniversary, right? And they found that people who do cohabitate together tend to have higher divorce rates. I said, oh no, this isn't good. Just proving my point here. Cosmo may be correct. However, I dug a little deeper and I was able to find, those men who were engaged at the time of cohabitation to their soon-to-be first wife had similar probabilities at 10 years as those who had been married first and then moved in together. I said, there's my ticket. I said, we're already engaged. The data says we should have the same rates of divorce as anyone else who got married first. And so, guess what? We moved in together and we're now at 5 years. So I think we're doing pretty good so far. We're not a statistic yet. So anyway, just to give you an idea of how sometimes you can have real world applications, right? Anyway, and again, very romantic when I was presenting my data to her and trying to convince her to do that. But it worked. Everything's going well. Anyway, right. So anyway, we jumped to conclusions. We are very hardwired to try to look at a small amount of data and try to generalize it out to a population. We're going to see there's going to be some issues with that. Just because you look at a sample of people, I could do a study with the 62, 61, 30, whatever of you, and I can try to say, well, this is obviously true for everyone in the United States. Now, is that accurate? I could look at your height. I could look at your blood pressure. I could look at blood type. Do you think that would be an accurate representation of all people in the U.S.? Why not? Small sample size, right? I only have like 60 some odd of you. Also, what's your cohort, right? Most of you guys are in your early 20s. Is that going to be applicable to looking at people who are in their 60s, 70s, 80s? No, right? The makeup of male versus female, of ethnicity, etc. And so you're going to find that it's very difficult, and you got to make sure you're looking at those sorts of things to make sure that, hey, you look at this small data set. Can that be applied out, right? We're going to talk about generalizability and how much that these small data sets can be applied to a larger population overall, right? And so again, it's very hard to make good, strong recommendations based off of limited data, as we'll see. So anyway, we try to see patterns, and again, I'm going to try to get you guys out here a little quickly. So here's one example of talking about, basketball players, right? I'm not huge into sports, but I'm at least familiar with the term of hot hands, where, people think if you get a couple of shots, you're more likely to make more shots, right? And so people just make that assumption and say, oh, he got a couple shots in a row and then he got several shots after that. It must be true, right? And so they actually were looking at data and they were going through and said, okay, or not. And they'll see in the next table here, they had 10 different basketball players, one for each row, and they had an X as being a successful shot and a dash being a minus here. Look at this. What do you think about it? Does it seem like there's a pattern here? Do you think there's actually anything to, successful shots begetting more successful shots? Kind of looks like it, right? See some runs of misses and hits, you think, okay, well, maybe there's something to this. But we can't just look at the pattern. We have to actually do the scientific rigor and look at the actual numbers. And you actually find this totally random, right? So actually it was about a 50-50 chance of actually making a shot or not. But again, just due to statistical error, just due to random chance, things tend to happen in runs like that, okay? Just like flipping a coin, basically. So even though we know that things may be random, we still like to see patterns. Like us, just as an evolutionary being, we like to look for patterns. I notice that the sun rises in the morning and goes down at nighttime, or during this time of year, this is a good time to plant these crops. Think back all the way to very early human times, but we like to see patterns. That's kind of how our brains have evolved to do that. We need to make sure we have a little bit more rigor from a medical standpoint of looking at this data and make sure we're not just looking for anecdotal evidence. We're not just looking at small data sets and being able to learn what kind of data is good to generalize out back to our patients, right? Because again, you can say, like, oh man, my aunt used this herbal supplement. She had all of her lupus went away and her blood pressure got corrected and all those kind of sorts of things. Would you then apply that to all of your patients? Would you make that recommendation? You can't, right? Because the anecdotal evidence is not going to be very scientifically rigorous, as we'll see. So we're going to look at that, see how we can try to get beyond that, make it a little bit better assumptions about our patients. Anyway, now one of the other things we realize is that coincidences are actually pretty common. Right, so, and I'll show you an example of this in just a second, but the chances of any two circumstances happening at the same time may seem like it's going to be pretty rare for the most part. So imagine, like, driving, getting into a car wreck. Now, most of you guys probably drove in today. Did any of you experience a car wreck? Fantastic, right? You did?
Oh, not today. But...
Oh. Okay, yeah, just let's use today as our example, right? So again, but were there a lot of car wrecks that happened today? Probably on I-4 and elsewhere? Probably, right? It was a very low probability that you personally had a car wreck, right? But these things happen every single day. So that's one of the things that we look at and need to make sure that we understand that these different coincidences do happen quite frequently. It just may not be happening to you or to your patient, etc. Example of this is the birthday paradox. Has anyone ever heard of the birthday paradox? Basically, it says, as far as anyone else in this room, what do you think the chances are that someone has the same birthday as you? Well, how many days in a year? 365. So the chances of someone having the same birthday as me is 1 in 365. It's pretty low chances, right? The chances of someone not having the same birthday as me is a lot better, right? So you see here something like 99.73%. However, what are the chances that at least there's a pair of people in this room right now that have the same birthday? You think it's pretty good? Don't think so? It's unlikely? Who thinks it's unlikely? Okay, so it seems, it's beeping anyway. Actually, if you look at the data, if you actually do the calculations here, which I'm not going to make you do, and again, assuming there's 62 people in here, including me, there's a 99.59% chance that at least 2 people in this room share the same birthday. You want to practice it? All right. Huh? You, all 3 of you, or oh, just you 2? Well, what's the birthday?
May 19.
May 19. Boom. Already proved me it didn't. Huh? Yeah. So there's already 2 sets. Just in a group of 60 some odd people, right? So I don't even have to do the whole room. But that's fantastic, right? So and oftentimes it's usually in the first row. Like I don't have to go like 5 or 6 people down before I find a match. So again, it's the chances of someone having the same birthday as you, very, very remote between you two. However, looking at a whole population tends to be a little bit more common than you think. Okay, so these are rare instances, rare coincidences that are more common than you might believe. So anyway, again, we have a lot of intuitive feelings about probabilities. So say, for instance, you have 2 bowls, one large and one small. In one of them, you have 9 white jelly beans and 1 red jelly bean. In the other bowl, you have 93 white jelly beans and 7 red jelly beans. Now, you get a prize if you get a red bean. Which one do you go with? Who would go with the one with the 9 white and 1 red? There's a couple. How about who would go with the 93 white, 7 red? Okay. A lot of you just said, I'm just not going to play this game. No, thank you. Seems like a trap. I'm not going to do it. Well, what you tend to find is that people make the illogical choice, right? So again, which one do you think has better probabilities of picking that red bean? You think it'd be the same? Well, looking at it, if I have 9 white and 1 red, what are the chances of picking that red one? 1 out of 10. A 10% chance of actually picking that. How about this one? Even though there's more red beans, it's only 7% chance, right? So realistically speaking, probability-wise, I'd have a better chance of picking that red one if I go with the first one. Even though there's a fewer number of red beans available, I only have 10 to pick from, right? So again, a lot logical choice. Say, for instance, you're looking at, and again, this is where things can get really screwy, where you can find like all these reports that get put out on like MSNBC or CNN or wherever they say, oh, this new study says that chocolate is going to give you 10 years added onto your lifespan, right? These are things where they can skew the numbers to really make things look better or worse than they actually are. So, for instance, most people, when you rate, there's a study where they're looking at cancer risk, right? So they're looking at the number of people who are killed by a particular cancer. People said that they rated it much riskier when it was 1,286 out of 10,000 people than it was for 24.14 out of 100. Which one has a higher risk? The second one, 24 people out of 100 is a heck of a lot more from a probability standpoint than just 1,200 out of 10,000, right? But again, people look at the numbers and say, well, that's 1,200 is a really big number. That must be more risky from that standpoint, right? So you can fudge a lot of things just by fudging the numbers. Okay, and again, looking at other ambiguous situations, imagine now you have two urns that are filled with jelly beans. Of course, I don't know how many urns I would want to pick a jelly bean out of. So what was that urn used for previously? But each one has 100 jelly beans in it. The first one has a 50-50 mix, so 50% red, 50% black. The second one has unknown ratio between red and black. Okay, now you get a prize if you get the red bean. Now, which urn do you choose from? 50-50 one or the unknown one? Unknown? Why? No idea. Just a hunch? Good feeling? Right, you're probably better off picking from the unknown ratio, because who's to say that it's not 99 red beans and 1 black, right? We don't know. But the thing is, beans are set to think, well, I just want to go with what's going to be what I know, right? So that ambiguity is going to be kind of a problem there, right? So again, when they did a study back in the 60s, almost everyone chose the first urn because you know the probabilities, you know it's 50-50. The second one, there's ambiguity. I'm not really sure. I'm not going to really impress my luck with that standpoint. But again, almost everyone chose the first urn in those cases there. And so if you even look at, like they did MRIs when looking at people dealing with like situations with a lot of ambiguity, they found a lot of the fear centers being activated in the amygdala, and then a lot of the pleasure centers actually being deactivated in those cases. So just as people, we don't like that ambiguity. You don't like not knowing what you're getting yourself into in a lot of cases. That makes total sense, I think. But again, going by the numbers, it makes more sense to go that second urn, because who knows, it could be 100 red beans for all we know, right? Okay. Has anyone heard of the Monty Hall problem? It's kind of a really interesting sort of stats sort of paradox thing. So imagine, there's the old Monty Hall shows back in the day, if you can tell from the picture. Imagine you have 3 doors, and behind one of them is a car or whatever prize you like, and the other 2 are going to be worthless, right? So again, there's nothing behind the other 2 doors. Now you, as a participant, get to choose a door, and then they'll open up one of the other doors that has nothing behind it, right? So now you know you've either got your door that you chose, and then either which has a prize behind it or not, or then you have the second door that may have the prize or not. You have no idea at this point, right? Now you have the opportunity to change your pick. You can go from door 1 to number 2, or not, or you can stick with the door that you have, right? Now the question is, should you switch? You don't think it matters? You don't think it matters? Interesting. Okay, so you think you should switch? Well, we're going to understand it. We're going to find out why it is that you should switch. Yes, sir.
You're supposed to switch because your odds go from 1/3 to 1/2.
Yes, basically that's what we're going to turn it out to be, and I'll show you an example here in a second. Let's participate. Who would like to participate with the Monty Hall problem? All right, which box would you like to go with? Left, middle, or right?
Middle.
Middle. Okay. This should work. I hope. Son of a gun. Why is this not working right? All right. Well, anyway, let's say we pick the middle one. Let's say we pick the middle one. Which one? Do you want to switch or do you want to stay the same?
We'll stay the same.
You want to stay the same? All right. So we got rid of this one, right? So we say this one has no prize behind it. Let's see what happens. It's not going to work again. Perfect. This worked last year beautifully, I might add. Anyway, but you were wrong. You should have switched in this case there. Okay. So it may seem like it's kind of rigged. It wasn't. This actually works when it does work. Anyway, let me show you why. We switched though. So imagine here's kind of 3 parallel tracks, and that's kind of how you have to think about the problem in order to get to the correct solution here. Again, you have choice 1, 2, and 3, right? So in this case, the cups always have the prize under cup 1, right? So in this first instance here, you're going to notice that you pick the right one this time, right? So you go ahead and get rid of one of the ones that's not correct, but then you decide to switch. Now, that was obviously the wrong choice. You just should have stayed with the one that you had picked in the first place, right? Let's look at the other two instances, though, right? So let's look at this one right here where you select this one. The one that has no prize on it is gone, and then you make the switch. Well, now you made the switch, you got the prize, right? On this other hand, on choice 3, again, you select the wrong one. There's an X here, and then you make the switch, and then boom, you got the prize. This means you have a higher probability of actually getting the prize by making the switch than not, right? Basically, sir.
Just statistically speaking, though, you still have, it comes down to 2 unknowns.
Mm-hmm.
So that's why it's kind of hard for me to wrap my mind around why.
Absolutely, exactly. That is why it is quite. Basically, your best bet is to switch because, again, if you stay with the one that you picked, you still only have that 1/3 chance that that was the right choice in the first place, right? But by virtue of the fact that we got rid of one of the wrong choices in the first place, by making that switch, you've now brought it down to a 50-50 chance of having it either be right or wrong. So would you rather have 1/3 of a chance to get that prize, or would you rather have a 50% chance? Probably 50%. 50% is greater than 33%, right?
But there's a 50% chance by switching to be right or wrong as well.
Absolutely, right? But again, if I didn't switch at all, I still only have 1/3 of a chance, 33%. So it'll break your brain a little bit. So I suggest go back and review it a little bit later. Like think about it, perseverate on it. There's some good YouTube videos out there as well. But again, it's one of those things where our brains are not really wired to think like that. We're not thinking through multiple tracks to try to determine what is the right choice here, right? Okay. Okay. Everyone with me? So anyway, so think about that. Again, it's one of those things where statistics are hard. Like they are pretty difficult. Let's look at though an actual clinical example though. Let's apply it back to actual patients you may be dealing with. Now there's a branch of statistics called Bayesian Statistics. These are called Bayesian calculations where basically, and we'll learn about this later, but you're going to take a piece of information and then apply it to a group that you're dealing with, a population, and then making inferences about things based on test results, basically, right? Because again, a big part of you diagnosing a patient with a disease state is going to be with laboratory tests, right? Deciding whether or not they need a rapid strep test or they need an HIV test, et cetera, right? So let's look at the example of HIV blood screens, okay? Now, if you looked at the general population, do you expect the prevalence of HIV pretty high or pretty low? Pretty low for the most part, right? So let's say, for instance, we have a 0.1% prevalence of people with HIV. So if I looked at the whole population of the US, 0.1% of those people would have HIV, right? Okay, so we have an antibody test. It's pretty accurate, but it's not quite perfect, right? Are there any perfect lab tests out there? You're gonna find there's not really any, right? So again, we'll talk about things like sensitivity and specificity later on, but let's say, for instance, we have 99% sensitivity here, okay? So now we've got to talk about, well, what are the chances of having a true positive versus a false positive here, right? Because again, if you're getting tested for HIV, do you want a false positive? Chances are you don't, right? That's going to change your day pretty quickly there, right? Probably want some more confirmatory testing, et cetera. But let's look at the instances of having these pop up here. So again, you can do the math yourself if you like, but just kind of follow along with me. So let's say we have 100,000 healthy people being tested from the community. We have no idea if they have HIV or not, right? We know that 0.1% of them will have HIV, right, based off of our previous assumption. Okay, so 100 of them should have HIV, right? Now, the test is going to be positive because we looked at that sensitivity there in 99 of them. So 99% sensitivity, as we said, those are going to be positive there. The other 99,900 people do not have HIV, but because this is only 99% specific, or sensitive, I should say, there's going to be that 1% who gets flagged, right? So we're going to find that you have incorrectly false positive of 1%. That 1% of 100,000 is 999 false positives. Does that sound reasonable, good, bad? It's almost 1,000 false positive people being tested for HIV. That's not good, right? You don't want to have that extra 100 people thinking they have HIV when they really don't. So adding that together, you see here that of the whole group, we only have about 9% true positives out of this whole bunch. Out of all the tests that showed positive, only 9% of them were true positives. Now, would you say that's a very good test? Not really. You're saying there's way too many false positives. This is not a very good test to use in these cases here. 91% of positive results were false positives. That sounds like a terrible test, right? Now, that means that if a test is positive, there's only 9% chance that patient actually has HIV. You say that's pretty crummy. You get pretty bad reviews from your patients. They told me I had HIV and had to have follow-up testing, all this blood work, and then came back negative. What the heck, right? No good. So that's in a population that has a really low prevalence of HIV. Case though, and again, when you see that result come back as a clinician, you see HIV positive, what do you think? they're HIV positive, right? And so you're going to be making treatment decisions based off of that. But we don't have a really good way as humans to really hardwire that data in to say, hey, well, wait a second, well, what's the prevalence of HIV in my population anyway? Is there really all these people with HIV we just didn't know about? Probably not, right? So let's go ahead and look at a different situation, a different prevalence rate, and see how that can influence our. So let's say, for instance, we have 100,000 IV drug abusers who are being tested. Now, what do you think about prevalence of HIV in people who abuse IV drugs? Higher, lower? Probably a lot higher, right? They're participating in a lot of risky behaviors, especially like things like needle sharing, et cetera, right? So let's say they have a 10% prevalence of HIV in that population, right? So out of that 100,000, 10,000 of them should have HIV based on our kind of this data that we have starting out with. That means that our test, again, being 99% sensitive, will be positive for 99% of those, so 9,900. The other 90,000 people who do not have HIV, right? And you're going to see that, again, we're going to have incorrectly returning back a positive result of 1%, which means, again, we're still having 900 false positives. Add those up. You can see here that we have 10,800 positive results. 92% of those total actually have HIV, which means that now we have 92% chance that if someone shows positive for HIV, that's actually true. Now, is that better than the 9% we saw last slide? Absolutely, right. So again, a lot of times it goes back into, well, who's the population I'm dealing with? Is it just the whole population of the U.S. as a whole, or is it going to be a specific subgroup, right? IV drug abusers, or prisoners, or anything like that, right? So again, sometimes knowing your population going into it can really make an influence on these results that you come back. So that way, if I know I'm dealing with an IV drug abuser and it comes back as positive HIV, you're much more confident in that result than it would be if it was someone who had no past medical history, no issues of drug dependence, anything like that. Okay, does that make sense? So again, this stuff is hard. This is why I'm trying to show it to you now, see how you can apply this and how it's going to become important for your patients later on. Okay. So again, a lot of interpretation results are going to be really dependent on the prevalence there. So for instance, things like flu tests, like when's flu season hit? Starting to kind of peak up now, so like the October timeframe up through maybe like even as far as May in some cases. So again, if I were to have a test that showed positive for flu in February, are you much more likely to think it's positive versus in July? Absolutely, because we know that the flu prevalence is much higher during flu season than not. So these are things that are going to be influencing how you respond to those results. Okay. Because you don't want to just get every single result back and just say, well, this is true. You need to go back and actually be a little bit more critical with it. Okay. Anyway. Okay, other things, we are oftentimes fooled by multiple comparisons. When I say multiple comparisons, anyone know what that means? Sometimes it's referred to as like mining for data. So here's a good example of this, where basically there's a study where they had 10 million residents of Ontario, Canada, and they were just kind of going through and just picking up every piece of data they can find, right? They were looking at 223 different reasons for hospital admission, and they tested to see is there any correlation between these admission reasons with their astrological sign. Is there any link, and again, if you truly believe this, I don't want to disparage you at all, but do the majority of you think that your astrological sign has an influence on the reason why you're being admitted to the hospital? Probably unlikely, right? So just because I'm a Cancer doesn't mean I'm getting admitted for cancer, right? I'm not, but just so you know, there's probably not a true linkage there. But what you're going to find is if you make enough comparisons, if you keep looking long enough and doing enough tests over and over and over again, is there a chance you're going to find something just by random chance? Absolutely. And this is one of the things you have to be aware of, is that there's often times where if you keep making different comparisons over and over and over again, just by random chance, you're going to find something. Okay. And this is oftentimes what you'll do, if you're working maybe with less rigorous research methodology and things like that. I remember I was talking to somebody, I think they were in the class last year, but they worked in a zoology lab in undergrad, and they had these results and they came back all negative based on their original hypothesis. And the professor who was running it, they're like, well, just keep looking for stuff until you find something, and then we'll just do that. Not good. Like, you can't do that. It's very inappropriate. But anyway, so again, this is a good example of like, okay, well, is there an actual relationship? Not. But when they actually looked at it, they were doing several different comparisons here. So 223 reasons times 12 astrological signs. They had all these different comparisons that were being made here, right? So looking at this, just by chance alone, and we'll see why 5% is the number we're going to use here, but just by chance alone, 5% of the time, you should find something positive. And positive, I mean like there's an actual association being made there when I say that. And looking at this, you would expect just by chance alone you'd have 134 significant associations, saying that you're more likely to be admitted for CHF exacerbation if you're Virgo, or you're coming in for an MI because you're a Leo or something like that, right? Now again, we know that's not true, at least unless there's some other bit of evidence showing us that that actually is true. But as far as we know right now, not true. And what they actually found they had 72 significant associations occurring just by chance alone, right? So they didn't even get as many as we would expect just by chance alone, but they found 72 significant associations. And this is where you see like these kind of crazy articles either come out on Facebook or CNN or whatever. They come out and they say, hey, look at the significant association. If you're a Leo, watch out for bears because these people had a significant association with bear attacks. It's Ontario, Canada. I imagine there's some bears up there. So right. So again, you have to be careful and look back at the source to be like, well, this study even makes sense in the first place. We also tend to ignore things like alternative explanations. So for instance, they did a study of acupuncture for osteoarthritis, right? And they were asked to rate their arthritic pain either both before and then after the treatment. And they found that pain decreased in most of those patients there. And they were finding that the statistical calculations show that this appeared to not be due to chance alone. This appeared to be a truly significant difference here. And the question is, well, the acupuncture must have worked, right? What are some alternative reasons that maybe the acupuncture wasn't working? Placebo effect? Absolutely. Placebo effect is much larger than you might actually imagine, right? Placebo effect is huge. What else? Yeah, so what else are they taking? Are they on aspirin? Are they on ibuprofen? Maybe they took a dose of ibuprofen and then got the acupuncture and all of a sudden their arthritic pain is lower? Perhaps. Could be one. Other things, if you were doing a survey and someone did all this nice acupuncture on you and they asked you, well, how's your pain now? Just being polite, you probably say, well, it wasn't 8 before, but now it's a 6. Maybe not. Who knows, right? Pain is a very subjective sort of thing. It'd be nice if I could hook someone up to a monitor and say, okay, your pain's a 4 right now, right? But we don't have that. Unfortunately, it's all what patients are reporting. So again, it's not to say that acupuncture does not work, but you have to look at these alternative explanations and say, well, I don't think it's this because X, Y, and Z. You need to have some rationale for why you're making these assumptions here and all that. So again, lots of different things we're going to be kind of evaluating here when looking at the medical literature to decide, like, is this good for my patient? Is this allowing me to make a better decision at the end of the day? Okay, so another thing, anyone ever heard the term regression to the mean? It's not like your teachers regress to being mean. No. So basically this means that if you see extreme results, either low or high results, they tend to go back to the average over time. So for instance, if I were to say, take someone's blood pressure right now, and it looked high, if I took it, say 10 minutes later, would it be high again? Possibly, right? The patient was hypertensive or something like that. But you can also find that, hey, maybe it actually goes back down. Okay, especially you see this a lot, like patients who are like walking around outside and they come in, get their blood pressure taken immediately, give them 5 minutes. They've been sitting down in a quiet, calm environment, and then all of a sudden it's lower. Okay, this is something called regression to the mean. We're going to find that typically extreme values tend to regress back to that population average over time, as you'll see. So for instance, this is a table where they were looking at just random blood pressure values. They just randomly assigned before and after. There's no actual clinical work going into these data points here. And it looks pretty random if you're looking at this, right? It looks like nothing actually happened with whatever treatment you're giving before and after. Now, if you were to separate these out and you were looking at all the high values and then you were looking at all the low values, what do you kind of notice? High values tended to become lower, and then the low values tended to trend up, right? And again, that's that phenomenon of regressing back to the mean. And this is one of the things we're trying to look at when we do statistical tests to make sure that we're not looking at that, right? Because again, this is normal. You'd expect this to happen. We want to make sure that if you're giving someone a drug or you're giving them a certain surgery, that you're actually making a true difference. And this is what we're going to be looking for here, right? Okay. Again, this is just kind of going through talking about that, how values tend to regress back to that mean. High values tend to get lower, low values tend to get higher, unless there actually is a true difference there, which is what statistical tests can help us to determine. Okay. Where are we at right now? All right. Let's see. I only have 20 slides left. You guys are okay if I don't give you a break and go straight through? Okay. I think, again, this is just kind of wetting your whistle a little bit, and then we'll get into the actual material next time. Okay, so let's get into statistics are so hard. Okay, so what are some problems with statistics that make it difficult sort of subject to approach? One is fear of math. Math is hard. I agree. You won't have to do a whole lot in this class. If you do, it's basic division or multiplication, okay, or addition and subtraction. Not hard, right? Confusing terminology. There's a lot of confusing terminology. Everyday words that we have for normal things tend to have a much different meaning when we're talking about statistics. And it's important to kind of delineate. When I say things like significant or I say things like positive associations, etc., what does that actually mean? Because normally you think positive, you think what? It's good, right? Positive doesn't necessarily mean good, right? If you're HIV positive, is that good? not usually, right? But there's a positive association between, say, being a Leo and getting mauled by a bear. That's not a good thing, right? But it means there's an association there, right? Versus a negative association or something like that. Again, a lot of abstract thinking. We've kind of covered that to some degree already. And then talking about probability, not certainty. Okay, so we'll go over a little bit more. Again, you can understand statistics, at least how we're going to be using them to interpret things like the medical literature without understanding exactly how they work, right? So again, when you order a lab test, say order a CBC on a patient, do you know what goes into collecting that blood, going to the lab, what reagents are going to be applying to it, what machine they're using, how to use the machine to get that blood result back? You guys aren't going to know that, right? You don't need to know that. You're the provider. You're just going to be getting the results back, making an interpretation, and going from there. The same thing's happening here. We don't need to know necessarily how to calculate standard deviations. We don't need to know how to, form confidence intervals. We don't need to know any of that stuff. We're going to have it reported to us, and we need to be able to make that leap to, okay, what does this actually mean? What sort of takeaways can I get from this piece of literature here? Okay, that doesn't mean you don't want to look at some scrutiny with how they cook their data a little bit there, but you don't need to know every single detail, right? So again, when something gets reported to you, and again, when we say when you're looking at an article that's in a, say for instance, JAMA, right, the Journal of the American Medical Association, do you think you'd have pretty good confidence that this is a good article as far as quality goes? In JAMA, right, the American Medical Association, it's probably pretty good, right? And again, it goes back to kind of the rigors that that article will be put through before it gets accepted for publication. So if anyone ever heard of like a peer-reviewed journal, what does that mean? It means that other people who are experts in the field have looked at it and said this article's good or it's bad, you need to go and revise it somewhat, right? So for instance, when I was doing my research in fellowship, I did it all on coral snake bites. Guess what? Coral snake bites are not super common, so there's not really a whole lot of experts that are out there. But when I wanted to publish that, I sent it into the journal. Clinical Toxicology was the journal, and they submitted it. They looked all through the data. They looked through the statistical tests we did. They looked through everything, and it said, hey, I think you should tweak this and this and this. I don't think this is correct. And then we went through, revised it, turned it back in, and then, okay, they said, yes, this is good. So you at least know with a peer-reviewed journal, you're getting pretty good evidence, right? You're getting some pretty good data that should be giving you good information to act on, right? Now, are there bad journals out there? 100%, right? I could pay $100 and have an article published that showed that chocolate decreases bear attacks, right? You can't prove that it doesn't, right? But the point is that there's some bad articles that are bad journals that are out there, but we want to look for things like peer-reviewed articles, right? Or peer-reviewed journals. Those are going to be able to give you a little bit more confidence that yes, this is good. But anywho, similarly looking at things like, imaging studies, you don't need to know how the MRI machine's working. You just want to get that report back and look at the image and say, okay, yes, you have a stroke or whatever the case may be, right? So next up, there's a lot of confusing terminology. And so it's kind of like, just like in pharm, how it's like learning another language. A little bit here is going to be the case where you're going to see there's different meanings for words you may be sort of used to, right? So for instance, when you hear the word significant, what does that mean? There's a lot of it. There's a hefty, again, you ever think about trying to define the word significant? Like, it's kind of hard, right? We'll talk about things like significance and meaning that two samples or two bits of data are truly different from one another, and they're not actually pulled from the same population, right? We're going to talk about some definition for those things. We'll talk about things like error. When you think of error, what is that? I made a boo-boo, right? So I didn't do something correct, or I made a mistake. Error in this case, we're going to find is going to be about just randomness of data, right? So when if I were to get the average blood pressure of everyone in this room, let's assume you're all nice and healthy. I'm going to say the average is 120/80. Is every single person here 120/80? Probably unlikely. Some people will be a little lower. Some people are going to be a little bit higher. And that randomness is going to be what we call error, right? So again, we're going to talk about these kind of specialized definitions for these words. And so just pay attention. This is a good list of things to pay attention to. We're going to cover these pretty extensively in class, okay? Again, abstract thinking, we're trying to take, with statistics, we want to take this data and try to make some strong conclusions about it. So for instance, when a patient comes up and say, hey, I have high blood pressure, and they say, well, what are the chances that this drug you put me on is going to get my blood pressure under control? How do you answer that question? Yes, pretty likely, or maybe it's not likely at all. Maybe it's not going to work. Do you ever say, like, yes, absolutely, this is going to work? Not often, right? Because again, there's always going to be some uncertainty. You're always going to have patients who are going to throw you for a loop. They're going to act abnormal. They're going to do things you don't expect them to do. And so we're trying to make these very concrete sort of assertions, but we need to do more with that, right? We need to learn how to take that and try to apply it back to our patients and say, well, I think there's a pretty good chance that this is going to get your blood pressure under control, or I think this is not going to be a good drug for you because X, Y, and Z, or maybe surgery, maybe your chances of survival are going to be X, Y, and Z percentage, whatever the case may be. Because of the fact that we're dealing with this abstract data and trying to apply it back to an individual patient you have right in front of you, right? Because that's what I want to get down to, is when you have patients that go, what's the chances of this drug actually working for me? You can go back to the literature and be like, well, for patients who are similar to you, they had, a 60% chance this actually got their blood pressure down in range, right? And you can communicate that sort of thing, and of course, bring it back to what your patient, as far as their education level, all that goes. But being able to apply that to actual people, right, that you're treating. And again, we're going to be talking about things like populations, probability distributions, null hypotheses. All these are going to be ingrained in your mind as we go through these. But these are things that can be kind of abstract in general, but we're going to try to give you a good definition and how to use these appropriately. Okay. Right, and so again, probability, not certainty, is the key here, right? So again, you'll never hear, or very rarely, again, never, right? It's pretty absolute, right? You're very unlikely to hear me say that, yes, this is going to work 100% of the time, or no, this is not going to work, because again, you're going to find there's always going to be some random error. There's always randomness to everything. Just for instance, when someone comes up and says, hey, how should I study for pharm? I said, well, this has worked for people before. I have no idea if it's going to work for you, right? I have no idea what your study habits are, what your learning style is, etc. But I can say at least this worked for a lot of people prior to you. No reason to think that it shouldn't work for you as well. Not 100%, but it should work. Things like that, right? So again, and all these statistics are just reporting probabilities. There's never a way to say like, yes, you're absolutely going to survive this surgery, or no, this cancer is not going to kill you, because we're dealing with probabilities, okay? Basically, it's a good way of never having to say you're certain. And guess what? It's totally okay to say, I don't know, right? As students, you're probably trained to never say, I don't know, right? Looks very bad if you say, I don't know something. But I don't know a ton of stuff. The amount of stuff I don't know could probably fill the whole world, right? So again, it's okay to say, I don't know. But, based on the data, I think that it's likely that you will survive the surgery, or I think it's unlikely that this is going to get your blood pressure under control, et cetera, right? So that's the thing here, is you never have to be certain of things. I'll tell you guys I don't know all the time. I'll tell you I'm not really sure, but I think that it's probably this, or it could be this, or it's likely to be this, things like that. Okay. So last bit of information here. We're talking about going from samples to populations. And when I say samples in the terms of statistics, what do you think that means? Samad? Yeah, small groups essentially, right? So again, say for instance, I wanted to do a study where I was looking at, say for instance, the incoming GPA of PA students and having that has some outcome on, say, on PANCE results, right? Now I could use all of you as my study subjects, right? Is this going to be representative of the population? There's probably some resemblances, right? So there's probably some degrees of similarities between you and other PA programs that are out there, but it's not going to be perfect, right? But you guys are going to be considered a sample, and then I can take that data and try to apply it out to the population. In this case, population would be all PA students who are coming into PA school, right? So when we talk about populations, we have to define what we're talking about. We're talking about samples. Again, we need to define that to make sure we understand, what that's going to mean. So for instance, if I was trying to look at the correlation between GPAs coming into PA school, could I apply that information out to, say, med school students? Well, no, the populations are totally different, right? So again, different types of programs, different degrees you're going to be earning at the end of, things like that. They're going to make it so that, well, that data is probably not generalizable. It doesn't make sense to apply that out. Similarly, if I was looking at, say, a blood pressure trial, and I was only looking at African American patients, could I extrapolate that data out to white patients or Hispanic patients? There could be some similarities there, but you're going to find that there's going to be enough differences where that may not be an appropriate sort of comparison. Okay, so again, populations and samples are really, really important to. Okay, some other things we're going to be looking at some context where you might actually see this generalization, right? So going from a small sample set and generalizing results back out to a population. Things like quality control. Things like political polls. I'm not going to get too political in this class by any means, but we'll use it as some examples because it is relevant as far as things like looking at populations and looking at samples, things like that. Clinical studies, lab experiments. So there's lots of good ways to express this. For example, though, let's look at quality control, right? So when Ford is making, we'll go with my pet favorite, Subaru. Let's say Subaru is making a bunch of cars, and they're putting them out on the line. Do they test every single car that comes through to make sure that it's perfect? What do they test? Probably a couple of them, right? They probably test a small subset of those. So you can say that, okay, we're testing these WRXs that are coming off the line. We're going to say check at 1 in every 10. They're using that small sample, that 1 out of every 10, that 10% of cars coming through, and trying to apply that. They say, well, this one looks pretty good. We should be able to generalize that out to all the other ones that are coming off the line, right? Does that make sense? Does that seem reasonable? I would probably say so, right? So it's easy when you're dealing with things like inanimate objects, right? And so again, we're using that data to try to make inferences about the entire population. I could use you guys as a subset of PA students and try to apply that information back out to all PA students in the US, right? Now, if I tried to apply it to PA students, say, in Europe, very few of those, but would there be any correlations there? Possibly, or maybe not. Who can say, right? We haven't done the data to show that. But again, looking at your sample is really, really important to decide, okay, does this make sense based on the population that I care about, okay? Political polls is a big one as well. You know, polling is done frequently to try to figure out how are people actually going to vote. How often are those polling results usually right? Well, you guys are too busy keeping up with PA school to have your finger on the pulse of politics, but I guarantee you they're wrong a lot of the time, right? So again, things like, you know, how are questions asked, you know, the time frame of things happening, what kind of news story broke that may have changed people's minds about things. You know, we use a small subset of voters to poll to ask them questions about what they're going to do, say, in the election coming up, and then try to expand that out to all voters, right? So, for instance, if I were to check, say, do a poll of who you're going to vote for governor, that's actually very topical, actually. So, who's going to vote for governor in Florida, and I tested just in Orange County, do you think that'd be, I can generalize that information back out to the entire state of Florida? If you look at the maps, Orange County tends to be a lot more blue than all the rest of the state is, right? So, if I apply it to Duval County, good old Duval, you know, from Duval County, you're not going to find that, right? That's basically just a little dip of the Bible Belt right there. So you're going to find very different results because of that. So questions like, well, who's your sample, and is that generalizable out to your actual patients that you care about? Clinical studies is another big one, right? So very frequently, you know, I'd like to do studies where I could look at the entire population of the U.S., but is that going to ever be possible? Not really, right? So because of that, due to the logistical concerns of that sort of things, typically we have to try to use those smaller samples to try to make those inferences there. And again, looking at things like, you know, is this a good drug? Well, who are the patients that are using it in? So for instance, if I was looking at, say, only male patients for a particular drug and seeing what the results would be, is that generalizable to female patients? It's not the best comparison to make, right? Because again, totally different physiologies. There could be definitely some hormonal influences involved. It could be all sorts of things. And so because of that, you need to go back and look at who the patient population was, or who the sample was, to see if that actually makes sense for the population, as I've kind of mentioned here. And lab experiments, this is going to be a little bit different. So for instance, when you're looking at, you know, data, that tends to be the sample. So if I run like a CBC on something, that's going to be the actual sample you're going to look at. Population is going to be a little bit more abstract than what we'll see. We're not going to deal with this too frequently, but if you get into doing research on, you know, laboratory studies or anything like that, you may deal with this a little bit modified sort of definition of samples and populations. But again, you know, going back to the clinical studies one, that's one we're going to probably be using most often. So anyway, so again, you know, what our calculations cannot do, you know, in theory, how we're going to apply our statistical analysis would be applied. Let's say we have like a very simple experiment we want to perform here. For one, the first thing you have to do is define who your population is, right? So whether I care about African-American females, or if I care about PA students, or I care about, I don't know, iguanas living in Bolivia, or whatever it happens to be, I'm going to define what my population is, okay? You need to randomly select a set of subjects to study. Why is that random really important? So bias is going to be a huge thing we're going to talk about later on in the class that can unduly influence the results of your study, right? So again, if you think about things like I want to do a study on a new drug, and I'm going to open it up, and I'm going to pay people $50 to take this drug and perform this study, and I just have all comers, just whoever comes in. Who do you think that's going to be motivating? People need $50, right? So again, this is where you can see sort of these things called like, you know, convenience samples and things like that. Are all the people coming in that need $50, is that going to be representative of the whole population? Maybe not, right? So again, these are things that you have to be addressing in your studies to show that, hey, we at least looked at this, we at least addressed it, and we know that this may be influencing our results. So again, you always want to be really transparent with research. So we randomly select our sample. And again, an ideal experiment, we would just break them into half. We could say, okay, this half of the room is going to get this drug, this half of the room is going to get placebo. Why is placebo good to test? You can look for a placebo effect, right? So again, if I give one drug to these, and again, I use drugs as an example because that's most of the studies I look at. If I give these patients in this half of the room the drug, in this half of the room to sugar pills, and I see the same drop in blood pressure or the same decrease in pain scores, that probably shows me that drug's probably not doing a whole lot, right? Placebo effect is a very strong sort of phenomenon that we need to account for. That's why you see a lot of placebo-controlled trials out there. But usually you're going to be measuring like a single variable. When I say a single variable, what could that be? Blood pressure, could be levels of hormones in the bloodstream, it could be blood sugar, it could be anything, right? So you set what the variable is if you're going to be running an experiment, and then based on the result, we get the data we get back, then that's when we're going to use our statistical test. It's going to be able to allow us to make inferences about that data to say, okay, well, is there any differences between these two groups? If there is, then how can we apply that back out to the general population, okay? And you can look at things like, look at the distribution of the data there to say, well, does this look normal, is it not normal? Normal is another thing that we'll talk about as far as the definition goes. It's very different for stats versus anything else, right? So like normally distributed data. And again, you don't want to use me as your definition of normal by any means, but also don't think about your normal definition for when it comes into stats. And again, you're going to find that a lot of times they run into problems when you're actually looking at the validity of these statistical results, right? So again, let's say, for instance, I want to do a study. I was looking at HIV patients, right? So I have a new drug. I want to see if it's effective for treatment of HIV, okay? So how would you design that study if you had to?
You can only just do a sample population of those who are known to be positive with HIV.
Yeah, so first step, you got to find people who are HIV positive, right, to see if they're going to get the drug or not, right? And then after that, what would you do?
You have to do you want to separate them out so like controlled and or like a those who are like a double blind.
Yeah, we'll talk about what double blind means a little bit later. It doesn't mean like you poke your patient's eyes out or anything like that. But we'll talk about what those sort of terms mean. But yes, like you want to separate your groups, right? You want to figure out, okay, well, this is my intervention. This is my control group. Control is another good term to kind of keep your eyes out for. And so with HIV, one of the things you want to see is, well, you know, we'd like to look at the entire population of people who have HIV, but that's going to be impossible, right? So perhaps we can look at a smaller sample, right? So that's where we're, again, no study is perfect. We're going to look at a smaller subset of that in order to identify as HIV positive patients. And then the question is, well, you know, ideally, what sort of outcomes are you going to look for? So with HIV treatment, what might you look at? Ideally, you'd like for them to live longer, right? Well, how easy is it to determine how long these patients are going to live for? It's pretty tough if they're living for several decades, right? So back in the 80s, you'd find the HIV patients did not live very long. That might have been more feasible. Nowadays, a lot of these patients are living much, much longer, decades, in fact. Can you run a study very easily for many decades? Nope, you can't. It's very difficult, very costly. A lot of times these studies are not done for that long. So what if I use like a surrogate outcome, right? So I can look at things like HIV viral load. I can look at things like CD4 count and use those as surrogates to say, well, I know their CD4 count's higher. That probably means they're going to be living for longer based on other data that I have that shows that, right? So these are things we're going to be looking at and say, what kind of outcomes are we looking at? Does that outcome actually make sense for what we actually care about, right? So again, similarly with like things like cardiovascular drugs, you know, yeah, we can get your blood pressure down, but are we going to wait till every single patient either has an MI or they die to determine whether or not they had cardiovascular death risk decrease? No, you can't do that, right? So we're going to look at things as surrogate outcomes to see, well, does this actually make a difference here, right? So, and again, realistically, you're going to find that your study population is going to be a lot more restrained than you might think. So, for instance, if you're looking at doing a study in San Francisco, so you're looking at only 20 to 40-year-old patients who are coming to the university clinic, right? This is where we're going to talk about exclusion and inclusion criteria. Exclusion and inclusion criteria. And so you're going to find that it's important to make sure you're singling out people based on certain parameters you would like to be able to control for. So for instance, you know, if I had an HIV patient who I wanted to test for this new drug, and they came in, they're already sick as snot, they have you know, all kinds of opportunistic infections, they're probably going to die pretty soon anyway, is that someone you want to include in your study? No, because they could, you know, falsely skew the results in the wrong direction, right? I mean, the patient's going to die anyway, so they would have skewed the results whatever group they get put into, right? You know, if they're on other experimental drugs already, that obviously would kind of screw your data one way versus another, right? That was having an effect. So again, you need to make sure you're excluding the right people, but including all the right people you want. So again, the question goes into like, well, how generalizable are these results? You know, if I only have 20 to 40-year-olds, is that going to be generalizable to the whole HIV population? Doesn't include kids, so I can't make any inferences about that. Doesn't include older patients who are now starting to live longer with HIV. So again, you're starting to see some of these limitations here. Again, I'm going to use something like CD4 count as a good proxy to try to determine survival. Obviously, a higher CD4 count means longer survival, hopefully, because they can fight off infections and things like that. And again, I'm going to use those findings to extrapolate out to the kind of wider HIV population at large. Okay. And again, it's not going to be perfect, but I'm going to try to make as many inferences as I can based on the data that I have. Okay. And again, sometimes you'll have what we call a meta-analysis, where we pull in a lot of different research papers and things like that together to look at things like, delayed reduction in CD4 count, prolongation of life, medical costs, side effects, et cetera, try to get a better idea of kind of what effect this actual drug is having on our patients. Again, we're going to find that the calculations are going to be kind of limited in how much they can help us out with some of these problems. So for instance, the population that I really care about is more diverse than the population sampled. This happens all the time, right? You find a lot of studies that are kind of cut short because they just can't get enough patients in, right? Or the patients are not diverse enough to be applicable. So if I don't have enough male patients coming in, or female patients, or patients of diverse enough ethnic background, all those can be pretty severe limitations when you try to generalize things out to the whole population there, right? As I mentioned, the subjects are not randomly sampled. So if I was paying people, money tends to be a pretty strong motivator for a lot of people. So that could skew results towards one type of person versus another. The actual variable I'm measuring, whether or not that's a good surrogate. I could look at, if I gave someone blood pressure medication and I was looking at their blood sugar, is that going to be a good surrogate for how good of a blood pressure med that is? Not really, right? So again, you want to make sure you're looking at the right kind of variable there. Okay, things need to be measured appropriately, right? So obviously, if I was accidentally, getting wrong results, or I was running the testing correctly, that can all be a big player here. And again, usually when you're making a clinical conclusion, you have to look at multiple outcomes, right? So you're not just looking at the amount of life that you're adding onto a patient, but maybe looking at how much does that actually cost to do so, right? Again, not everyone's made out of money, and if something's too expensive, they oftentimes don't have access to that sort of care. So that can be a big role to play as well. So, and again, our results are always going to be somewhat vague to some degree, and we're going to be making pretty general conclusions about the limited data sets that we have in here. And it's really important to, make sure that we're including words such as things like probably, most likely, almost certainly. And again, we're never saying yes, no, 100%, because we cannot make those sorts of assertions without testing the entire population, right? Unless I tested every single HIV patient, there's no way I can say that absolutely this drug's going to work, or it doesn't work, or whatever the case may be, right? Which ones do you think sounds more surefire, right? So probably, almost certainly. Almost certainly, right? So again, tailoring your language to show how confident you are in the results here, right? So if I have for instance, if I have someone I do this all the time when I have patients who are overdose patients, and I have the docs calling me on call for the poison center and say, hey, what are the chances if I do this intervention that this is actually going to make a difference for the patient? And again, I'm never going to be like, absolutely, this is going to make a difference. I'm going to say, well, it's most likely to cause a difference because, again, we have data to show that, yes, this causes improved mortality, or decreased mortality for these patients here, right? Things like that to try to show that, I'm confident, but I can't say with 100% certainty, right? Because I never want to back yourself into that sort of corner where you said, someone can come back to you and say, well, you said this would work. And I say, whoa, I said it probably will work. Didn't say it absolutely will work, okay? And again, be aware, anytime you hear someone say statistically significant, that's always going to be something you want to keep your eyes out for as well, because again, we're going to talk about clinical significance versus statistic significance. Which one do you think is more important? Clinical significance, right? So again, I can do a drug trial where I see that this drug causes a 3 millimeter mercury drop in blood pressure, and it's statistically significant. Do you actually care about that? No, it's 3 millimeters of mercury. Who cares, right? I want to see 10, 20, 30-point reduction there from a hypertensive patient. So again, you can have things that are statistically significant. It's a minuscule amount of difference there. You want clinical significance, and that's what I'm going to try to hone you guys in on seeing is like, okay, you got these results. Well, how do you make any difference out of that? Is this even clinically significant? If not, chuck it. Who cares? We don't need that data. Okay. Okay, we'll also talk about models. So again, anytime you're dealing with calculations, so calculating things like body surface area, creatinine clearance, anything like that, those calculations came from a study, right? So Cockcroft-Gault is one of the most common ones I talk about. That model had to come from a study where basically they took a bunch of patients, they did testing on to see what their creatinine clearance was, and then basically what they did is took that data and tried to fit it into a calculation that most accurately could then be used to extrapolate that out to other patients, right? So again, this is why it's going to be really important. We talk about this later. That defining, well, who's your population? Who are you actually looking at? If Cockcroft and Gault originally did the study and say 20-year-old healthy males, you end up seeing that a lot, like studies done back in the 40s and 50s, where there's a lot higher male propensity and relatively healthy individuals, and saying like, okay, well, does that apply to the patients I have today, right? Who may be older, more comorbid conditions, female patients, things like that. But again, oftentimes you may not have great information to work off of, but we got to do what we got to do, right? So again, models are not perfect, but that's also something we'll talk about a little bit later in this class as well. And again, know that the probability of things versus the statistics are going to be a little bit different here, as we're going to see. Typically, when we're dealing with probability, we're going to be looking at general sort of results and trying to apply them into specific cases here, right? So again, I'm taking information that I have and I learned in school or I learned from reading a paper and applying that to my individual patients. When they go, is this going to work for me? You can give them some sort of probability to think, well, in a study that looked at people that were very similar to you, 95% of them had improved effects. That's applying something very general to someone who's very specific right in front of you, right? Versus with statistics, you're kind of doing the opposite, right? So when you're actually doing the studies, this is where you're looking at a very small subset of patients, right? And then applying that back out to the general population. So a little bit of difference between those two. Just know with statistics, we're kind of starting with the small data and extrapolating that out. With probabilities, when you're dealing with your patients individually, you're taking all this data from the research articles, et cetera, the textbooks, and applying that down to your individual patient, okay? So that is the intro to this course. I'm trying to get you out here a little early. Is there any questions I can answer before we start? So again, this is just kind of the general intro. We're going to get into the nitty-gritty of it moving forward. Questions at all? All right, you guys have a great weekend. I will see you next time. Hopefully the AC will work.